Hello, my name is Leanne and welcome to Blackboard Pharmacology. Welcome to the second video of the cardiovascular system, and today we're going to discuss congestive heart failure. So, congestive heart failure is when the heart doesn't pump adequate amounts of blood to the body and thus not enough oxygen is delivered to the cells. The most common causes are coronary artery disease and hypertension. So there's two types of heart failure: systolic failure and diastolic failure. Systolic failure is more often seen in the younger patients, and this happens when the contractility of the heart decreases, and thus the amount of blood being ejected isn't enough to meet the oxygen requirements of the body. This is typical of acute failure that usually occurs after a myocardial infarction. Diastolic failure, on the other hand, is reduced filling of the heart due to hypertrophy, which can be due to stiffening of the heart muscle. Then the heart can't relax sufficiently. Here the ejection fraction can be normal. This type of failure doesn't respond to drugs such as digoxin. These symptoms happen due to compensatory responses of the body. So firstly, you're going to have a decrease in cardiac output. If we look at the left-hand side, this is going to lead to a decrease carotid sinus firing, which in turn is going to increase sympathetic discharge. And when sympathetic discharge is increased, it's going to lead to increased force, increased heart rate, increased preload, and an increased afterload. While when you look at the right-hand side, the renal blood flow is also going to decrease, but the renin concentration is going to increase, and thus the concentration of angiotensin II will increase. This is going to cause an increase in preload and an increase in afterload, and also remodeling. So when we go back to the sympathetic discharge, a lot of the symptoms can be explained by the sympathetic discharge that increased. So it's going to include tachycardia, a decrease in exercise tolerance, shortness of breath, and peripheral and pulmonary edema. Remodeling basically just means stretch in the heart muscle due to structural changes, and this can lead to hypertrophy, for example. To understand congestive heart failure better, we need to look at how cardiac contractility happens. So we're going to start by looking at the Purkinje fiber. So cardiac muscles are electrically excitable, but they differ from other muscle cells because they have this intrinsic rhythm that spontaneously happens, and this is made possible by pacemaker cells. So if we look at the sketch and we start at the first phase, which is phase 0, it's going to be described to be a fast upstroke. This is due to sodium channels that open, and this causes an influx of sodium into the cell. Then as soon as the upstroke ends, sodium channels are closed. Phase 1 is partial repolarization. This is the initial rapid phase of repolarization, and it happens due to the inactivation of the sodium channels and the potassium channels that rapidly opens, which causes a fast outmove of potassium out of the cell. Phase 2 is going to describe the plateau. So here the voltage-sensitive calcium channels open, and this causes an inward depolarization because the calcium is going to move inside to the cell while the potassium exits the cell. Phase 3 is going to be repolarization, and this happens when the calcium channels close. So now potassium channels open. Now potassium can exit the cell, forming an outward current, and this is what leads to the membrane repolarization. The net result of the action at this point is a gain of sodium ions and a loss of potassium ions. So phase 4 is the forward current. And here it's increasing in depolarization due to an increase in sodium permeability. The spontaneous depolarization automatically brings the cell to the threshold so that it's ready for the next action potential. Let's move on to the contraction of a cardiac muscle cell due to the movement of ions. So there are two different sites on the cell membrane where digoxin and calcium channel blockers bind to. Digoxin uses your sodium-potassium ATPase pump, while calcium channel blockers will bind to the L-type calcium channel. So when the calcium enters the cell through the ports that's located on the cell membrane, we're going to call it trigger calcium. And that trigger calcium is going to enter the cell's sarcoplasmic reticulum through a calcium transporter, which then pumps activated calcium from the sarcoplasmic reticulum. Calcium synthesizers act at the actin-troponin tropomyosin complex, where activator calcium enables the interaction of myosin and actin filaments. These filaments are located in the cardiac sarcomere. Then a contraction can occur. So the removal of cytosolic calcium happens through the sodium-calcium exchanger pump. Calcium ions get exchanged for sodium ions. It also happens when calcium is taken up by the sarcoplasmic reticulum and the mitochondria. Now we're going to move on to the drugs that we use to treat congestive heart failure with. It's going to be furosemide, hydrochlorothiazide, spironolactone, enalapril or captopril, losartan, carfentanil, digoxin, and one I forgot to add to the list when I wrote, vasodilators. Alright, so furosemide is a loop diuretic, and it decreases the sodium chloride and the potassium chloride in the nephron. This causes an increase of salt and water excretion. It reduces cardiac preload and afterload, and it reduces venous pressure. It also reduces pulmonary and peripheral edema. So it's going to be used in the treatment of acute and chronic heart failure, severe hypertension, and edematous conditions. Side effects will include hypovolemia, hypokalemia, orthostatic hypertension, ototoxicity, and sulfonamide allergy. The reduction in cardiac size improves the pump's efficiency, and this is important in systolic heart failure. It's important to remember that if sodium is excreted, potassium is also excreted, and thus this is quite hazardous to use in patients that's on digoxin treatment. Hypokalemia can be treated with potassium supplements, or you can add an ACE inhibitor or a potassium-sparing diuretic such as spironolactone. So hydrochlorothiazide is only going to decrease the sodium chloride reabsorption in the nephron. The effects that it has on the heart is very similar to that of furosemide, and we are going to use it in the treatment for mild chronic failure and hypercalciuria. The side effects will also correlate with furosemide, and it will include hyponatremia, hypokalemia, hyperglycemia, hyperuricemia, hyperlipidemia, and sulfonamide allergies. So spironolactone is an aldosterone antagonist, and we also call it a potassium-sparing diuretic. It blocks aldosterone receptors in the nephron, so it increases salt and water excretion. This medication is used in chronic heart failure, aldosteronism, and hypertension. It has the side effects of hyperkalemia, and it's an anti-androgenic drug. Alright, so the angiotensin antagonists is going to include the angiotensin converting enzyme inhibitors, also known as ACE inhibitors, and these two is the captopril and enalapril. It inhibits ACE, and thus it inhibits the conversion of angiotensin 1 to angiotensin 2. In the heart, it's going to cause arteriolar and venous dilatation. It also reduces the aldosterone secretion. So we're going to use this in the treatment for chronic heart failure, hypertension, and diabetic renal diseases. Some of the side effects of these drugs is coughing, angioneurotic edema, and hyperkalemia. So basically, less angiotensin means less sympathomimetic activity. It reduces the angiotensin's effect on norepinephrine, and it's the first line treatment if no edema is present. So it's going to reduce the afterload, it's going to reduce the salt and water retention, and thus reduce the preload. Very important to know is that you can't replace digoxin in a patient that is already started on digoxin therapy. Angiotensin receptor blockers. It's going to be, example, losartan. And it antagonizes all the effects of angiotensin 2 by blocking that angiotensin receptor. The effects that it has on the heart is going to be similar to your ACE inhibitors. And we're going to use it in patients that is intolerant to ACE inhibitors due to that side effect of coughing. So side effects for losartan is going to be hyperkalemia as well as angioneurotic edema. Beta blockers. Example, carfentanil. It blocks the beta-1 receptors. Thus, it slows the heart rate and it reduces the blood pressure. It also slows down the progression of chronic heart failure. So these drugs reduces the effects of catecholamines, and it can sometimes take up to months before improvement is seen. So the side effects include bronchospasms, bradycardia, atrioventricular block, and acute cardiac decompensation. And digoxin is an inhibitor of the sodium-potassium ATPase pump. It reduces calcium from moving out of the cell and thus increases the calcium stored in the sarcoplasmic reticulum. In this way, it can increase cardiac contractility and also increase the parasympathomimetic effect on the heart. It's usually used in chronic heart failure and atrial fibrillations. Side effects include nausea, vomiting, diarrhea, and cardiac arrhythmias. Our last drug for this video is going to be the vasodilators, and these drugs are usually effective in acute heart failure. They reduce the preload and the afterload by influencing the dilation of the arteries and the veins. It can also reduce remodeling of the heart when hydralazine and isosorbide dinitrate is used in combination. So long-acting nitrates is going to be used in patients where the main symptom is dyspnea, where hydralazine is going to be used where the main symptom is fatigue. Long-acting nitrates helps with pulmonary congestion and is used in patients with a high filling pressure, while hydralazine increases the cardiac output by increasing your nitric oxide synthesis. Side effects include tachycardia, fluid retention, and lupus-like syndrome. Thank you for watching, and if you feel like you need to broaden your pharmacology knowledge, please check out some of my other videos.